Hello, everyone. I am Dr. Ahmed D. Abdulwahab, and this is Highlights in Radiology. Meningioma is an intracranial tumor that we see a lot during the daily practice of brain CT scans and MRIs. So there are multiple imaging details to meningioma that we need to know about. In this episode, we will talk about the meningioma and how it looks and what are the types and all other details. Stay with me. We will see it. Let's start. The meningioma, it's an extra-axial tumor. It's arises from tissues outside the brain parenchyma. It's the most common meningeal tumor by far, and it's located anywhere where meninges are found. So in today's episode, we will talk only about the intracranial meningiomas. We will not talk about the spinal meningiomas. They are easily diagnosed, typically indolent, not malignant, very benign behavior. It has a low rate of recurrence following surgery, but keep in mind there are about 15 subtypes of histological grades, and some of them will have aggressive behavior and higher grade, like going into malignant lesion. The typical meningioma appear as a dural-based masses. They are iso-intense to gray matter on T1 and or on T2, and they enhance vividly marked post-contrast enhancement or CT and MRI. They are more common in women, around 2 to 1, women to men, and in the intracranial part, and they are 4 to 1 in the spine. So spinal meningiomas usually happens much more commonly in women than in men. It's very uncommon in patients less than 40 years of age. And if you see it in less than 40 years of age, just keep in mind it might be part of a neurofibromatosis type 2. As we said, meningiomas can happen anywhere where meninges are found. So in this demonstration, we will see where are the most common locations of meningioma. Here we can see what's called the olfactory groove meningioma. This is the planum sphenoidale meningioma, sphenoiding meningioma, and the clinoid process meningioma, tuberculum silli meningioma, cavernous sinus meningioma. It's a recognized type, and the petroclival meningioma usually occur in this location. If it is here, it will called the cerebellopontine angle meningioma, foramen magnum meningioma. Over the cerebellar convexity or tentorial meningiomas are also well-known locations. And in the coronal image here, we can see the most common type, which is convexity or cerebral convexity meningioma, and the falcine meningioma, parasagittal falcine meningioma are also well-recognized locations. So, what are the radiographic features of meningioma? The best imaging modality for meningioma, it's definitely the MRI with contrast, and it will accurately show you the tumor, if there is any intra or transosseous extension in relationship, and its relationship to the underlying brain. CT is also useful if you need bony anatomy, like for example at the skull base, the CT will be helpful. Also, if the patient cannot do MRI, maybe claustrophobic or have some MRI contraindication like metallic foreign bodies in the body of the patient. Also, if the meningioma is entirely calcified or ossified, which happens in a small percentage of meningiomas. So, let's start by plain radiographs. Plain radiographs in general does not have a role nowadays, but there are a number of features that you can see. Example of that is enlarged meningeal artery groove and hyperostosis, or even lytic lesion can be due to meningioma. Some calcification or displacement of a calcified pineal gland or choroid plexus due to mass effect by the meningioma. For example, in this case, you can see the calcified lesion or showing some calcification, and this you should suspect presence of a meningioma. Another example here, you can see there is some lucency if you compare to the other side. This is suspicious for presence of a lesion, which is in this case was a meningioma. Another example, if it is entirely calcified lesion, you can see it here causing mass effect, displacing the falx cerebri to the right side, and it was a meningioma. Here is an example of a meningioma showing like a lytic lesion. You can see here there is a lytic lesion here in the skull, and it was a meningioma. On CT scan, if it is not contrast CT, without contrast, we will see a lesion that's slightly hyperdense to normal brain. Most of the meningiomas will be isodense, and it may have some calcification, around 20-25%, and demonstrate variable adjacent edema. The surrounding brain might have no edema or just some mild edema. After contrast, it will brightly and homogeneously enhance. If you see more heterogeneous or less intense contrast enhancement, suspect the presence of a malignant or cystic variant of meningioma. The pattern of enhancement of meningioma is known as mother-in-law sign. Mother-in-law comes early and leave late. So is the meningioma. It enhances early and it stays enhanced for a late while. For example, in this CT scan, I know the image is not very well, but it's a very good example. You can see here surrounding an edema of the this part of the brain in the posterior temporal occipital areas of the cerebrum. And when we give contrast, you will see that there is a very well markedly homogeneously enhanced lesion on the right side of the falx cerebri, and it's surrounded by some vasogenic edema. Another example you can see here, this is the meningioma, okay, and it has some calcification. After contrast, it shows less prominent contrast enhancement, suggesting the possibility of presence of some malignant changes. Let's see this example. You can see this big tumor, it's slightly hyperdense to the brain parenchyma. It contains calcification with underlying hyperostosis of the skull. And another example you can see here, this meningioma, it's irregular outline. There is underlying hyperostosis. It's multilobulated and bulging into the brain, causing some mass effect. And this is suspicious for possible malignant transformation. Now, the hyperostosis that we see on CT is typical for meningiomas that abut the base of the skull. And here we need to distinguish this hyperostosis from direct skull vault invasion by the meningioma, like the meningioma is invading the skull, or could be a primary intraosseous meningioma. It's not on the meninges, it's in the bone due to presence of some meningeal rests within the bone. For example, you can see here, this is a skull-based meningioma that's primary intraosseous. You can see the pattern of hyperostosis that you see here. Another example, here you might think it's some sort of fibrous dysplasia, but it was a primary intraosseous meningioma due to presence of hyperostosis, and this is very difficult to distinguish. You need a lot of imaging to say that. Another example of primary intraosseous meningioma, you can see this big hyperostosis in the bone. And on MRI, the meningioma will look as an extraaxial mass with a broad dural base, and it's usually homogeneous, well circumscribed, like in this condition, in this patient here. You can see this meningioma that's big, dural based, and it's most likely, it's very homogeneous, and it's enhancing. The signal characteristics on MRI on T1, usually it's iso or hypointense to gray matter, while on T1 post-contrast, As we said, mother-in-law sign comes early, leaves late. It will show intense homogeneous post-contrast enhancement. And on T2 weighted images, it will show iso-intense or even hyper-intense signal to the gray matter, and maybe hypo-intense to gray matter, especially in cases of presence of calcification. On diffusion weighted images, the higher grade meningiomas like grade 2 and 3 may show greater than expected restricted diffusion. So on diffusion imaging, if you see diffusion restriction, think of a higher grade meningioma. For example, let's look at this case. This is a T1 weighted MRI of this meningioma. You can see it's almost iso-intense to the gray matter, and on T2 it's hyper-intense with some surrounding edema. Okay. Again, on the sagittal image, you can see the lesion with the surrounding edema here, and on coronal images, also you see this sphenoid wing meningioma with surrounding edema, and it's hyper-intense. On post-contrast image, you can see this large parasagittal meningioma with intense, bright, homogeneous post-contrast enhancement. It's dural-based. Look at this lesion here. We have some area of edema. We are not sure what's going on here. And on T2, it's almost iso-intense to the brain. And on diffusion, it has a restricted diffusion. So we should suspect something higher grade. And when we give contrast, you can see it's multilobulated, heterogeneously enhancing lesion, suggesting a higher grade meningioma. Let's see this case. This is a parasagittal meningioma. It's hypointense on T1 and hyperintense on T2. And again, on T1 and on T2, you can see the lesion with surrounding vasogenic edema, and it's causing mass effect. This heterogeneity can be suspicious for higher grade meningiomas. On MR spectroscopy, there are some criteria that we need to look for. We usually don't do MR spectroscopy for meningiomas, but there are some findings. For example, there is an increase in the alanine peak, which we can see here. The alanine peak is showing off. Also, there is increase in the glutamine and the glutamate, and which should be somewhere around here. There is increase in the choline, and since it's not from brain tissue, the NAA will be reduced or even absent in this condition, and the creatinine is very low or even absent. So these are the spectroscopic criteria for meningioma. There are a few signs that we see a lot and might help us to decide whether this is a meningioma or not. For example, CSF cleft sign, it's not specific for meningioma, but helps to establish whether the mass is extraaxial or not. Loss of the CSF cleft sign might suggest that the tumor is invading the brain parenchyma. CSF cleft sign, basically, it's the presence of a CSF signal between the tumor and the adjacent brain parenchyma. If you look carefully here, there is a CSF, small amount of CSF between the tumor and the brain parenchyma, and this is what we call CSF cleft sign. If you look at this lesion, does it look like a meningioma or not? Well, if you look carefully, you can see a small, faint CSF cleft here between the lesion and the brain, and this is a CSF cleft sign confirming that's an extraaxial tumor, which the presence of the heterogeneous signal intensity suggests it's a higher grade meningioma. The presence of a CSF cleft will help us to confirm that this is an extraaxial lesion, and in this case, it's a meningioma. The dural tail sign, it's a very well-known sign, which helps us to distinguish that this is a meningeal lesion, and most commonly it's seen in meningioma. Other signs that we can see here, it's the sunburst or spoke wheel appearance. You can see the feeding vessels just going like that, like the sunburst pattern, which is also a feature of meningioma. And you can see also what's called the buckling, white matter buckling sign. You can see the white matter here is buckled. We'll see a lot of examples in the coming slides. For example, in this slide, you can see this is the meningioma, and you can see very clearly the dural tail sign. The spoke wheel sign, due to the feeding vessels coming from the meningioma, also known as sunburst or spoke wheel, whatever you like, you can see the feeding vessels coming from the vascular pedicle, like here, also here. It's the same sign, it's called spoke wheel, just like the spokes of a wheel, like that, or the sunburst. It's the same sign, two different names for the same thing. Now, let's look at this one. It has a very well seen sunburst or spoke wheel appearance, and if you look carefully, there is also the white matter buckling sign. The white matter is buckled underneath the lesion. Another example, which has like all kinds of findings here. You can see the CSF cleft sign, very clearly demonstrated. You can see the sunburst or spoke wheel appearance sign. And if you look, you can see the buckling of the white matter, which we can see here. The white matter is buckled or crumbled by the presence of the lesion. Another example of white matter buckling sign, you can see the white matter with the CSF cleft here, confirming it's an extraaxial lesion, which is a meningioma. Now, let's look at another sign, that's the arterial narrowing. It's seen in meningiomas that encase the arteries, and it's very useful in the paracellular tumor. Is it a meningioma or is it a pituitary macroadenoma? The pituitary macroadenoma does not compress vessels. It's encasing the vessels but does not cause narrowing of the vessel, while the meningioma encases vessels and cause narrowing of the vessel. This is a very important thing to see. For example, this lesion here, is it a pituitary macroadenoma or is it a meningioma? If you look at this tiny black dot here, it's narrowed. Just compare this one with this one. You can see this is the artery, it's normal caliber. Here it's narrowed. On MR angio, you can see this normal vessel here, while this is a narrowed or compressed vessel here. This presence of arterial narrowing is much in favor of meningioma. If you do a 3D FLAIR image, the peripheral limb of enhancement between meningioma and the brain will help you decide that this is a meningioma, not other dural-based tumors. Like example here, this is a 3D FLAIR. Post-contrast, you can see the enhancement at the periphery of the lesion, helping us to decide that this is a meningioma, not other dural-based tumor. This is just a T1 post-contrast. So, this will be the end of this presentation. I just want to remind you to subscribe and share and to like, and to help us continue presenting these episodes. If you have any questions or comments, please write it in the comment section, and I will be happy to answer. If you have any suggestions for topics to be presented in the coming episodes, please share it with us. We will try to do it. Thank you very much for watching and listening. This was Dr. Ahmed D. Abdulwahab, and this is Highlights in Radiology. See you next Friday. Bye.